How would you feel if you were in the need to buy a new car and you're in the market to get a car, and maybe not a brand new car, but a good used car, and you found one that was advertised and you went to see it, you walked on the lot, and the sales rep approaches you and you say, I want to look at this particular car, and you see the car and he talks about all the features of it, tells you that it is in good condition, very reliable, dependable, and mechanically very, very sound. And so you buy the car, it comes with a 90-day warranty, so all is fine. And so about 6 months later, you begin to find out there's some problems with this car, so you take it to your mechanic. And lo and behold, unbeknownst to you, the dealer had actually disconnected the check engine light. There were some underlying problems, but they did not tell you about it. But now it's beyond the warranty, and now you're really stuck with that car, even though it has problems. Folks, that's really the way it is when many people get Medicare Advantage plans. The rep makes them sound real good, talks about all the features and benefits, but the check engine light's been disconnected. They don't really tell you some of the underlying problems with Advantage plans. Well, why is that? Well, because they make more commission when you get a Medicare Advantage plan. But you need to know, if you contemplate getting a Medicare Advantage plan, there are some underlying problems. So we're not going to disconnect the warning light. We're actually going to talk about those in this video, because many people get Advantage plans and they feel stuck in them, and I don't want that to happen to you. Now, most of you that have watched some of the videos on our YouTube channel know that really what I try to do is really just speak from my heart to your heart, to make sure that you have the truth about Medicare, your choices, and really the consequences of those choices. And so normally I share information with you, but today I'm doing things just a little bit differently. In that I have found a couple articles and I thought would be very helpful for really the context of this particular video. And so I'm going to read some of those to you. But just before I do, I do want to make sure that everyone's clear, especially those of you that may be new to our channel or maybe new to Medicare. I want to make sure that we're clear as we talk about Advantage plans, that Advantage plans really is just one of the three options that we have when we go on Medicare. So let's go back and let's talk about these just real quickly, and then I'll get into these articles. So when we decide we're going to go on Medicare, notice we have three insurance options, and all these options are completely different, but you cannot be on all of them. You have to choose one of the three. All right, so the first one really, in my opinion, is the worst option, and that is when someone that just simply enrolls in a Medicare A and B only. In other words, beyond the Medicare insurance that's offered, A is hospitalization, B is the outpatient medical side. That's all they have. Now, the problem with this option is it's very risky financially, because Medicare pays, but Medicare doesn't pay for anything 100% other than preventive services. So you're going to have a balance of the bill. The biggest risk here really is on the B side. You're responsible after a small deductible of 20% coinsurance, and it never stops. So if you have any kind of a serious health issue, every doctor you see, if you have a surgeon, anesthesiologist, you're responsible for 20% of the bill. And so that's why I'm saying this is not a good option whatsoever. They say right now that about 10% of the Medicare population chooses A and B only. The second option would be, instead of being liable for all those gaps, now we can buy a Medigap policy, also called a supplemental policy. Most people that buy today are buying a G plan, which covers 5 of the 6 gaps, or the N plan, which covers 4 of the 6 gaps, plus it also has some copays involved as well. See a doctor, got a copay, go to the emergency room, also have a copay. And so, again, these are your top 2 plans. On average right now, I'd say those are running anywhere from $150 to maybe $130 a month. These are going to be in the range of probably $90 to $100 a month. So these are a little bit cheaper, but you take on just a little bit more risk and some copays with that. But my point is, people that don't want to take the risk up here of A and B only can transfer the risk to an insurance company. You pay a premium when you do that. Now, when we do that, notice we have to have a drug plan that's also called a separate or standalone drug plan. So that is option number 2. Right now, I think there's about 40% of all people that have a supplemental plan or some type of secondary insurance. Now, the third option has grown in popularity today. This is about 50% of the Medicare population that will do this, and they get what's called a replacement plan. Now, they're enrolled in A and B, but instead of having the government involved in the claims and the decisions and overseeing their care, now they have a private health insurance company that's replaced their A and B. Now, they're still paying Medicare, but they replaced it with a C plan. Now, I want to note something real quickly and make sure you're clear. there's two ways we can get a C plan. Now, the majority of people are going to get a C plan with an integrated Part D plan. And this was what I would do, unless over here you can do without a Part D plan, which means you can get your meds through the VA, through TRICARE for Life, which is retired military insurance, or your retired civil service. You have what's called FEHB, Federal Employee Health Benefits. They could get by with this. So this is called an MA-only plan. Over here, this is called an MAPD plan, Medicare Advantage, which is inpatient, outpatient, but also it includes prescription drug plan. All right, so that's the two ways in which Medicare Advantage plans can be bought and set up. All right, so those are our three options. Now, I'm going to focus really on this right here during the subject of this video, and we're actually going to compare option number 2 and option number 3. Okay, so before I get into that comparison, I do want to read just a few statements from this article that I thought would be very helpful. Those of you who've watched my channel know that really I'm not a fan of Medicare Advantage plans for certainly all people. I think some people can afford a little extra premium and get premium insurance. Some people cannot afford that. Then I think an Advantage plan is it's a good option because frankly it's their only option. They can't afford a little extra premium, and so they will go with an Advantage plan. All right, and so I want to make sure we're clear. Some people it is a good fit, but my main thing is I want to make sure that when people get an Advantage plan, they're fully educated, they understand exactly what they're going to get into, because so many agents, they disconnect the warning button, they disconnect that check engine light, they hide the problems instead of talking about some of the issues that people are going to have to be faced with, and then they encounter problems, health issues, and then all of a sudden the check engine light's flashing and they realize, wow, what have I gotten myself into? And I don't want that to happen to anyone. Hey, if you found this video helpful and you want to see more Medicare information just like it, then go below, right below the video, and you can give us the thumbs up as well as subscribe to our channel. And every time I put a new video, which is about 2 every week, you'll be notified of that video, and others just like you who need this vital information will get it as well. So let me do just a couple things. I thought this is very interesting. Now, this article was just out, and the article is actually talking about a very important meeting within the government. There's a group called MedPAC, and here's what the article says. A Medicare Payment Advisory Commission, so this is a government commission, this MedPAC meeting turned unusually contentious on Friday. Now, today I'm shooting this video. It is Wednesday, the 17th of January. Okay, so this meeting was just past Friday, which would have been January the 12th. So this meeting turned unusually, it says, contentious on Friday. The subject that caused this issue was a slide presentation that is posted for the public, and then following that, a lengthy report that only the commissioners that were in the meeting can read. And this report was highlighting growing concerns with the rapidly increasing amounts of Medicare funds now flowing to Medicare Advantage plans. Many chimed in during the meeting with a wide array of adjacent frustrations they've heard about Medicare Advantage plans from, listen, providers and patients dealing with narrow networks, prior authorization practices that delay or deny care, and extravagant broker commissions that result in steering confused seniors into plans without their understanding of what they may be giving up. And again, that's the whole philosophy of our company. Yes, we are insurance brokers. We write all kinds of plans, but we want to make sure people get an education first. Why? Because it's a big decision. And so a lot of agents don't have that conviction. They just simply want to sell something that's going to pay them the highest commission, regardless of the coverage that's being offered by or to that client. Let's keep going. This report goes on to say 52% of beneficiaries are now enrolled in Medicare Advantage plans, a fact that prompted many commissioners in the meeting to note, listen, a sense of urgency that aspects of the Medicare Advantage program have gotten out of control. One commissioner said this: the reason I feel a sense of urgency is we keep coming back to this issue that Medicare Advantage has never yielded aggregate savings to the Medicare program, despite that being one of its core goals. Meaning, when it started in 2003, they were going to deliver this great savings. They have not at all. 21 years now, they have not. Another commissioner noted this. This is an interesting statement. She says this is not the big, lovely, glowing success that everybody says it is, the Medicare Advantage plan. And we continue to create policies that drive people into these plans. And she referred to the fact that Medicare allows money paid to Medicare Advantage plans to be used for broker commissions. We get paid these as high as $600 to recruit them. And then they get another $300 every year. They stay on the plans. And here's her point. She says, we have allowed Medicare Advantage to buy the market. And that is why Medicare Advantage is growing. It's not because of the quality that's so great. People don't love their prior authorizations. They're leaving the plans a lot. Another commissioner said this, that while policy experts maintain that MA plan growth is propelled by patient preferences, meaning people want it because of what's being offered, they said the real reason may be because of how brokers are pitching the plans to their clients. Again, that's why I said they disconnect the warning light and people don't realize what they're getting. He goes on to say, increasingly, I get the sense brokers have a pretty large role and they're paid quite a bit to enroll people in Medicare Advantage plans. Well, sure we do. People need help with all this. And if someone's unethical, they're not going to tell you about all your options or the problems you may have if you get on an Advantage plan. They go on. Another commissioner says this in regards to Medicare Advantage plan quality. We're hearing a crescendo of commentary around the country about prior authorizations being a big issue now for Medicare Advantage patients. He says it's not just hospitals and doctors that someone has to be concerned about being in the network with a plan. She also said that said that some MA plans may not include contracts for care at inpatient rehab or skilled nursing facilities or home health care agencies. In other words, not even an option for you because the plan doesn't even contract with those providers. So what are you going to do if no one's in your network? Well, you're going to have to go without that care. And they said many aspects of the plan differences have gotten really complex. Yeah, that's what makes it difficult. Noted that some Medicare Advantage, another person noted this, some Medicare Advantage beneficiaries may have trouble getting cancer care in MA plans limited networks. And she was referring to a recent story that I have here in my notes about an MA enrollee who couldn't get the cancer care he needed from his MA plan and couldn't get out of it, his MA plan, without facing expensive copays. And this person said, when you're 65 and aging into the program, you're healthy. At that time, you may not be thinking about your long-term needs. What are you usually thinking about? The perks being offered, not problems you may encounter, which would push you to think harder about the specialty network that you may have access to in the plan or not. All right, just one more quick article. This just came out January the 3rd. And this article was titled, Older Americans Say They Feel Trapped in MA Plans. And the article says, for many seniors, the plans hid some serious problems they only learned about later on. Seniors are routinely barraged with a range of Medicare Advantage ads that often sound too good to be true, boasting better prices and a wide range of services. Many seniors quickly decide to switch to a plan that saves them money up front. They're enticing because many do not charge premiums and include other services like dental care. This simplicity and extra benefits prove to be a big draw, especially for people who do not have any urgent health problems. But the ads tend to neglect to mention the difficulty most seniors face if they want to return to traditional Medicare. I'm going to talk about that. They also don't say that for some, opting for these plans will make your treatment much farther away and not with a doctor of your choice. Such plans tend to have small networks where specific services require prior approval, thus delaying a treatment. Seniors, especially when their health degrades more, they feel stuck in these plans. So that's my point. This is all the country now. It's a huge problem. So let's look at the details of why we are seeing these types of issues today. All right, so let's do a difference between number 2, which was A and B with a supplemental plan, and then the option number 3, which was that Advantage plan, the C plan. All right, let's just lay these side by side. Now, there's only one item that these two systems have in common, and that is you have to be enrolled in Medicare A and B to have a supplemental plan or an Advantage plan. Now, for most people, the Medicare A is going to be zero. As long as we have 40 quarters, 10 years worth of taxes paid into Medicare, there's no premium on Medicare Part A for life. But B always has a premium based upon your income. Right now, that premium is $174.70 a month. For most people, I think about 85% of the population pay what we call the base premium. So if you're a single filer and you're below $103,000 a year, or a married couple filing a joint return below $206,000 a year, that would be the right premium. If you're above that, single above 103, couple above 206, you're going to pay more. I'm not going to get into that right now other than to say you're going to have a surcharge that's called an IRMA, income related monthly adjustment amount, that's added to your Medicare B as well as to the D. The lowest IRMA right now is about $83. The highest one's pushing about $500 a month. And again, it'd be very high income for that. But the point is, you have to be enrolled in Medicare A and B. Now let's look at all the differences. Number one difference would be that if you have a supplemental plan, you can notice you can go to any Medicare provider. So as long as the doctor or the hospital takes Medicare, go wherever you want, they will take your supplemental plan. That is different if we go with an Advantage plan. We are absolutely going to have a network, an HMO or a PPO. HMO networks are the most common. There are certainly PPO plans. HMO networks do, though, have some issues. Now, the positive about the HMOs, we look at these, is the HMO always has more favorable financial terms, meaning lower copays, lower max out-of-pockets, richer perks. In other words, they really make the HMOs more attractive than the PPO. It's just the way it works. But the problem is, on the HMO, you can't go out of your network. You're confined to your network. The only way you can go out of your network is if it's an emergency. Otherwise, you got to stay in. If you go out non-emergency, you have to pay for it 100%. The plan will not participate. So you're restricted to the doctors, hospitals that are going to take that particular plan. Now, the PPO, larger network for sure, and you can go out, but you're on a PPO and you go on the network, it costs a tremendous amount more money. In other words, if I stay in my PPO network, I may spend anywhere from $4,000 to $7,000 a year out of pocket. If I go out, it could cost me $10,000 to $12,000 a year. Over here, we never deal with that. All right, so my whole point is you have networks in this. HMOs sometimes require a referral to see a specialist. So there's some issues that come up with networks you got to be aware of, okay? And so again, what am I doing? I'm just showing you the check engine light here. These are some of the things I want you to be mindful of. Now, secondly, when it comes to supplemental plans, they're premium-based plan. You pay a premium. Remember, I said the G plan in the neighborhood of maybe $115 to $130 a month. Now, you be in a state that's a little lower, higher, the N plan somewhere between $90 to $100 a month. But we pay a premium, and we transfer the majority of the liability to the insurance company, so we're not responsible for it. Remember, the G, you pay only one gap, that's the B deductible. The N, you pay B deductible, excess charges, and you have some copays that you're responsible for. And so the point is most of everything is transferred to the insurance company, so we pay a premium. Over here, Advantage plan, we paid Medicare, but usually there's no premium we have to pay the insurance company. It's zero premium. Two out of every three plans is zero. If there is a premium, it's usually very low. Why is that? Well, because now what you're going to do is you pay as you go for whatever healthcare services you need. Now, there are a few pay-as-you-go, a few services that you don't have to pay. You usually see a primary care doctor for zero. Could be some basic lab work for zero. So there's some zeros for sure. But you're not going to go to the hospital for free unless you're on Medicaid. You're not going to have an operation free, outpatient. You're not going to see a specialist for free. You're not going to have an MRI or a CAT scan for free. You are going to pay as you go until you hit the max out of pocket for the year. And again, most HMOs now are somewhere between $3,000 to $4,000, PPOs between $4,000 to $7,000. But we're going to pay as we go. Either way, you're going to pay. Hey, if you're finding this video to be helpful and you would like to learn more about Medicare, you'll notice up here in the right-hand corner, there's an I. And if you'll click on that I, it's going to take you to a 20-minute workshop. I see people make mistakes all the time, and we don't want that to happen to you. And that's why we're giving you free access to this workshop. So go ahead, click the link, and learn more about Medicare. All right, now thirdly, notice the difference in these policies. Supplemental plans are lifetime. Once you have a supplemental policy, it can never be canceled by the insurance company except through non-payment of premium. So as long as you pay your premium, it can never be canceled. I don't care if you have lots of claims or you're very old or you move, all that. It doesn't matter. As long as you pay the premium, it's a lifetime policy. But you'll notice when it comes to Advantage plans, they're not lifetime. They're 1 year at a time. The plans come and go. Companies come and go. They could be here 1 year and gone the next year. They're very fluid because they're just a 1 year agreement between Medicare, the insurance company, and you. That's it, annually. Notice when it comes to supplemental plans, they're portable. So if you live in Denver, Colorado, and you're going to move to Miami, Florida, take your supplemental plan with you. Why? It's tied to you. It's a lifetime policy. They can't cancel because you relocate. Not so with Advantage. It's tied not to you, it's tied to a service area, a metropolitan area, a network of doctors. And so if you move from Denver to Miami, you're going to get a new Advantage plan whenever you move. Difference in policy. Also, supplemental plans. Notice little to no perks. So the gym membership, the dental allowance, the over-the-counter card, a lot of these things that you see advertised on TV, you're not going to see these with supplemental plans. Why? Their focus is premium insurance. That's what it's all about. Cadillac insurance, not a lot of perks. So you have to buy your own gym membership. You have to have your own dental plan if you want one of those. It's just separate. Over here, lots of perks. And they advertise these, and this is what the agents focus on. What I want you to focus on, yeah, those are nice, but how is your insurance going to work if you get cancer? That's the whole point of those articles, the point of the complaints. What's going to happen to you if you need an MRI or a knee replacement or a hip replacement? Are you going to be able to get those kinds of things, right? So don't just focus on the perks. All right, now next. Pre-authorizations. This is probably the biggest problem right now with Advantage plans, but you'll notice with supplemental plans, we don't have pre-authorizations. That means that if Medicare says we'll cover a service and your doctor says you need it, insurance company has no say-so whatsoever. They follow Medicare. Medicare pays, they have to pay. Medicare doesn't, they won't, but if Medicare pays, they will pay. So that insurance company can never interfere, can never override what the doctor is saying that you need, ever. Cannot happen. With Advantage plans, it can happen, absolutely. About 70% of the services needed on the Advantage will have to be pre-approved. Doctor says you need it, the story's not over like it was here. You have to get now approval by the insurance company. They have to agree with what the doctor is saying. And sometimes they do immediately, but sometimes they delay it, or they'll say, no, we want alternative care. We want you to go to therapy first before the knee or hip replacement, or we'll pay for a rod, not a full hip. We're not going to pay for that CAT scan yet. We want you just to take meds for a while, or whatever. There's all kinds of ways in which they can interfere and delay. And again, there's all kinds of reports out today showing that this is what these insurance companies are doing, and really causing people either to have delayed care or denied care that they really do need through the pre-authorization process. And then standalone drug plan versus integrated. Over here, if I get a supplemental plan, I actually get to pick out my own drug plan based upon the meds I take, the pharmacy I want to go to. Over in this system, it's integrated. You don't pick it out. Now, by the way, it could be wonderful, maybe wonderful. Sometimes they're good, sometimes they're mediocre. But again, they have selected your drug plan. It's just part of the package, all right? So here it's different, and we can change these on an annual basis if our meds move up or down year to year. And then lastly, this is very important. I'll close with this, critical here, you understand, because this is what one of the articles that I referred to was talking about. There was a gentleman in the article that actually was diagnosed with malignant melanoma. He realized that his care is not going to get what he really needed, and so he wanted to get off the plan, but he could not get off the plan, right, because he had cancer. And so here's what happens. When I want to buy a Medigap policy, the best time to buy one is tied to the B date of my Medicare, not the A date, but the B date. And sometimes A and B is the same, sometimes it's different. But the B date, what happens in every state in the country, I have a 6-month window where I can get any Medigap policy that's available in my state. Any company, any letter that I want to buy, I can have that without any underwriting. 6 months of my B date. Now, practically, I can apply 3 to 6 months in advance, so I don't have to wait for my B to start. But officially, my Medigap open enrollment period tied to my B date lasts for 6 months. And in all but 4 states, if you ever try to get a Medigap policy beyond that 6 months, now you have to medically qualify. We have to ask you 30 health questions, check your meds, get a statement from your doctor. There's a process, and now that insurance company does not have to take you. If you have pre-existing conditions, you're taking meds they're not comfortable with, they can flat say, we're not going to approve the policy. During that 6-month window, they must, but afterwards they don't, unless you live in New York, Connecticut, Maine, or Massachusetts. Okay, they don't have the 6-month window. You actually get a MedSup plan anytime in those 4 states, but all the other 46 and the District of Columbia, could be your one only chance to get a Medigap policy. So keep that in mind. Now let's talk about Medicare Advantage. If someone takes a Medicare Advantage plan and they stay on that plan for a year, 2 years, 3 years, 5 years, whatever period of time they stay on that, say 7 years, and now they want to get off it and they want to come back over into this system right here. Now they have to medically qualify to get that supplemental plan. Okay, so when they're going to want to switch, now we have to ask them 30 health questions. Check all their medication. We go through that process. And so if their health has changed in any way where they have some kind of, fairly minor to serious issue going on, that insurance company may not approve them, then they will be in this system for the rest of their life, okay? And by the way, it's sometimes not life or death issues. Someone that's just an insulin-dependent diabetic, some companies will not take you. If you have AFib in your medical records or spinal stenosis, rheumatoid arthritis, those kind of things, a company does not have to take you, and they oftentimes will not take you. So you're in this system. Doesn't mean you have no insurance, doesn't mean you're stuck in a terrible, terrible plan, but it does mean now for the rest of your life, you're always dealing with networks, paying out of pocket, till the max out of pocket. We're going to have, we have little perks, but when you're 80, you're probably going to care about the gym membership. You're going to care about how your insurance is going to work, working through all these issues that come with that Advantage plan. And so again, sometimes they're appealing at 65, but you got to be thinking long term, am I going to be happy with this if something happens to my health? And we always say it this way, folks, it's really not a matter of if, it's usually a matter of when. And we just don't know the when. And we just want to make sure that if you take an Advantage plan, you understand exactly what you're getting. All right? So all I've done in this video is this. I just simply reconnected the check engine light to make sure you understand there's some warnings. And so I hope you'll heed those warnings and make sure that you're comfortable with that Advantage plan if that's what you decide to do.